This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you very much for the invitation to speak to Daryl and the organising committee, and Lavin for your exceptionally kind words that I feel completely undeserving for. So today I'm going to be speaking about the epidemiology of the private system, and I really started doing work in the area when I moved to Cabrini in 2007, and I was sitting in my office in the Cabrini Research Institute, and I kept on hearing the MET calls going to the day oncology unit. So I had to go down there and find out what was the reason for them going off all the time in the day oncology unit. And, they started explaining to me that they really had to call them because the patients were starting to have reactions to the drugs when they were being put on them, the chemotherapy for the first time, and they didn't have any protocols, and they had to actually call the MET team to get the appropriate treatment. So that's where I started with, and then I sort of started thinking about it, and I was thinking, I've always been looking for something. In my background is critical care nursing, and I kind of always wanted a hook of something that joined critical care nursing with my research, which was focusing on decision making. So I thought this was a really good area to start, which is why I've taken the last number of years to really focus in the area. So what I'm going to do is just give you a little bit of an overview of the hospital setting and MET, the different types of studies that I've done. You can see that I've got quite a list, and I'd like to just tell you that I moved to the Alfred Hospital 2 years ago, and Jonathan Barrett has kindly sent me through some outcome data that he's collected recently, so I've been able to add that in the end just to show you the picture of what's going on still. So all this research was done at Cabrini Hospital, which is about a 450-bed private hospital in Malvern, but it also has another campus in Brighton, which has about 120 beds. They both have different types of MET systems. The MET system was established at Cabrini, Malvern in 2003. So when I actually arrived, there hadn't been anything that had been, no one had done any outcome studies. They were collecting the information in a register, but no one had actually analysed the register. So I sort of took the approach that it was a good point to start. So this figure is really probably familiar to all of you because, Michael put it up this morning, but it's also something that I've used quite a lot in situating where we needed to go with the research and where I saw the problems arising. And so we started off with looking at, well, what are the outcomes of what's the extent of the problem, what are the outcomes of patients who actually have MET calls in a private setting. So in terms of what we looked at, we were looking at the outcomes, but we were also looking at the reasons for the calls. So we were trying to find out were there any particular areas, such as the day oncology area, that were really coming up as high flyers, that we could look at specific interventions that perhaps could slow that down. So in terms of the outcomes, it really showed, in terms of the areas, we had a delayed MET of about 8%, transfers to ICU 15.6%, to CCU there was quite a high number, there was a huge number of the NFR and the death during MET. And this seemed a fairly high code blue call too. There was approximately 1.74 METs per 1,000 bed days at this stage. This data was collected on 295 patients, and you can see there that the really common criteria for the calls were around respiratory factors, and also when we looked at the charts, the nurse concern was often related to respiratory problems. There were clear reasons for the calls, but they were when they had to state what the calls were for, they would say that I'm just concerned. So they often wouldn't articulate what the physiological reasons were, even though they were also there. So as Lavin said, there's actually a paucity of information around about the private setting, so we really had nothing to compare it to. So I went to the public literature to see, well, how did these results to compare? And what I saw was that there was actually less delay on the MET calls, and that's quite significant. Less NFR after MET. Similar to the public system, the MET calls were mostly in the morning, and also that 77% had this respiratory criteria, but there was really low recognition by the nursing staff at that stage of importance. And what we saw was a lot of radar obs being graphed, so they'd be going along respiratory rates 16, 16, 16, even though that wasn't clearly the case when their SATs were dropping. And so we really thought about it and thought, well, there's less delay in some of the decision-making because the nurse rings the consultant directly, so you don't have to go through this hierarchical nature that Larvin identified as well. So the next step was really where to with this information. It was quite obvious that we needed to go and do some work in the afferent limb area. And in terms of this issue, we really were saying, because at that stage the numbers were going higher and higher in the number of MET calls, and so we were interested to know, well, how many patients are really out there that are sick? So what we did, we put together a multi-site study with funding support from the Commission to actually look at a set of vital signs on all patients in hospitals across 10 hospitals, a mix of both private and public. What we found from over 2,000 patients that we recruited to this study, that there were quite a number of patients, you can see here in the criteria, that had criteria, so they had vital signs that were already charted that they were abnormal on the vital signs chart. And when the nurses, we had 80 student nurses going to the 10 hospitals to collect data, when we did that, we found that there were patients who were actually, at that point in time when the nurses took a set of vital signs, they had these abnormal vital signs. And so we can see here that there was 55 patients that were essentially just sitting there with these abnormal signs. So it did vary. So the 24 hours you can see was 5.3 and then 3.3 at the time. So this research was published in Resuscitation, and what we really showed that, of course, there was this high mortality rate with patients that did have this criteria. Again, the number that went on and had MET calls was actually significant, was really, really low. And part of the protocol for this study was that the nurse in charge was actually notified that the patient had abnormal vital signs at the time. When we really analysed this and went back and looked at the charts, we looked at particularly about the limitations of medical treatment, and there were a large number of these that had limitations of medical treatment. So it did become a factor, and particularly when you look at the outcome data. But you can see that there was a high number of these patients were public patients, and they were the non-elective ones typically. So what this showed is that in the 24-hour period, there was between 1 in 30 and 1 in 20 patients fulfilled these MET criteria, but there was a really low MET activation rate that was occurring despite the presence of the MET vital signs that had such a significant outcome for patients. We really didn't know what the antecedent events, though, were, and what they were, why weren't these calls made, why didn't they escalate on, even though it was drawn to their attention and so forth. So really we were starting to say, well, what's going on? We need to do more work at looking at that picture of why this is not occurring. So we did a study, we tried to look at, just at the Cabrini Hospital, at Cabrini Health, we've got 2 campuses there, and one campus has a medical-led MET, the other one has a nursing-led MET. So it was a good opportunity to survey them using Daryl Jones's survey that has been used widely at a number of hospitals internationally and interstate. And we actually thought, well, we were wondering if there was going to be differences in some of these findings. You know, I guess I kind of thought that maybe a nurse-led MET might have nurses more likely to escalate to a nurse-led MET than what they might with a medical-led MET, because we'd had some reports that the nurses felt a little bit insecure in sometimes activating the medical-led MET. I apologise for the busyness of these slides, but so we had about 429 nurses respond to the study, and overall they felt really positive about the MET, so that was a really good sign, and they weren't really too fussed about calling it, which was good. Very few, really only 10% feared criticism. Some felt that there was a little bit of de-skilling in managing sick patients, but mostly they felt that I think it was an interesting point that 16.7% were required for inadequate medical management. And, you know, I guess that was a quite surprising thing. But still 7.1 also said it for nursing mismanagement. So that's something that we really haven't explored at this point. The activation of a MET call, most would call if the patient fulfilled MET, even if they didn't look unwell, but there were a large number who were quite uncertain, and that's the nature of a paper survey, is that you really can get some of that ambivalence coming through, which you really don't know how to account for. I think, interestingly, that Campus A nurses, where there was a medical-led MET, would not make a MET call when indicated if their patient looked unwell, 21%, so a fifth of the time, compared with the Campus B ones, which was where there was a nurse-led MET. And you can see also Campus B nurses were also more likely to activate a MET when worried about a patient despite normal vital signs. So that sort of tells me a little bit that they did feel a little bit more secure calling another nurse than perhaps initiating with a medical staff member. Most of them, about half, said they would agree to contact the covering doctor before a MET. So there, again, we only had a single tier system in place, so it was MET or nothing. So you've got this ambiguity about who to call first. And also, in terms of again, the Campus B nurses were less likely to call the covering doctor before a MET. So again, they were going to call the MET team first, and it was the nurse-led MET they were calling. This is another study we did because we were interested to know how many missed METs we had at Cabrini. And so Jessica Gwinnane is the gorgeous person up in the picture up here, and this is her master's degree. This process for this project, what we did was actually take a group of patients over a 1-week period, a 7-day period, and all of them were followed for their entire hospitalisation. So every observation chart that had been completed during that hospitalisation was reviewed, and we were looking to see whether they'd had missed METs or not. So there were 568 patients in this group, and you can see that you go down to those that fulfilled MET criteria, there was 14.4%. So this is a group that's sort of giving us a really good idea of what the picture of the hospitalisation looks like and what sort of resources might be needed in order to deal with them if you're going to have just the MET team dealing with them. Certainly of those, not all were patients that were in the ward, but the 69 that were in the ward, only 2 actually went on to have a MET call. So again, you're getting this large number that are not escalated. So this study was conducted in about 2010, 2011. So it's, we've moved on in terms of the external sheets, graphic observation charts and the policies of Standard 9 and things like that now. So the medical patients were more likely to fulfil MET criteria. That's not surprising to anybody. BP was the main reason for the call, less than 90 systolic blood pressure. But the interesting thing was that we had a hospital double length of stay for those if they did fulfil MET criteria. So this has significant resource implications. So 1 in 10 patients fulfilled MET criteria for this study, and despite hospital policy, only 1 in 27 chance of receiving a MET call. So it's not really very good. So we were interested to know, well, what are the nurses doing with their vital signs? How are we going, what are they actually doing? How are they making decisions about it? So this was an honours student that did this project, and she just looked at the nurses taking a set of vital signs in 1 paediatric ward. So it's certainly not generalisable to adult areas or any other hospital, but this is just to give you an idea of some of the findings that came up. So she observed the nurses, then she asked them afterwards whether they'd had any abnormal vital signs or what they'd done with them, and she also looked at the medical record to actually check whether they'd referred on or done anything. The interesting things that I think are important this predated the number of charts that actually had age-specific MET criteria. So because of that, there were nurses really left to making quite subjective decisions about when they did anything. There was also a policy that patients under 14 didn't routinely have blood pressures, and so you can see here they've got this really low group taking blood pressures. The really interesting thing, there was this heavy dependence on doing automatic readings. So they would take oxygen saturations and get a heart rate from the equipment, and they didn't actually touch, and at no point did my students see them touch the patient, which I found appalling as a nurse. These are children too. And, even the notion of they didn't assess pain scores, and the majority of the patients were in for elective surgery, tonsils and a lot of things like that. So the other really worrying thing is that even when they had abnormal readings, they actually didn't typically refer it on. So that's concerning. And this is another study which Jessica progressed from a master's degree onto a PhD study, and now she's studying patient and family perspectives of responses to medical emergencies. And I'm not going to talk about this here because there's a presentation this afternoon scheduled in another room, so I'll just quickly pass over that. If you want to hear more about that one, you can come to that presentation. And then lastly, this is an analysis of the MET register and patient records that Jonathan and Gabrielle Horden have done at Cabrini Health, and they've been collecting the patient outcomes now for about 6 years, and really been looking at the outcomes and then comparing them over that time. And I think one of the things that we have seen is that METs mature over time, and the issues around understanding that culture change that goes on, and all the things that have happened with the standard change and the policy drivers that have become so important in all our lives now with the standards. This is really a nice way of mapping it. Unfortunately, the data wasn't sent to me where it was for per 1,000 bed days, so I can't give it to you, but I've just got literally the percentages. But just to highlight, there's a continuing trend where it was pretty much going up, except there was this year that it didn't, and I'm not sure why that was low. And if we knew the hospital admission rate, that might perhaps account for that. You can see that that whole year is a bit abnormal, but if you ignore that, you can see that there's this trend going downwards, and so forth across the pathway. And these are all percentages, so you can get a good idea about how they move over time. Particularly, disappointingly, we haven't seen much around the NFR area. So really, to conclude, the patient demographics are important for outcomes, and Larvin mentioned that earlier, and I think we can't underestimate that we've got elective surgery and so forth. But in a lot of our hospitals now in the private settings where they do have emergencies, they do get a lot of medical patients now with the chronicity associated with that. So it's more and more important that we understand that demographic. It disappoints me to know that there isn't that much research done in the private setting, and I think we need to do a bit more that way of when we're running studies at the public settings, that we also concurrently run them at the private, so we really can see some of those differences, because given the large number of patients that go through private settings, and probably most of us here have private health cover and will one day end up in the private setting, I'm sure we want to know that the setting is actually functioning at its highest level. The different model of medical care, I think, is a really important factor in some of those differences, and I think that warrants some more following about the different types of decision making. The changing context, both internal and external, is also important. It's been a major driver in public hospitals, but it's also a major driver in private settings. So I think it's important that we do more work in this area, and I'm sure Larvin would be happy to collaborate in any way possible. Thank you very much.